So hi everyone, as I said, I am Charlotte Tai. I am a respiratory and crit care consultant based at Barts Health in London. Today I'm going to talk to you about pulmonary embolism. It's a really big topic. We only have half an hour, but what I'm going to aim to do is try and go through sort of the big concepts in terms of what are the key things you need to note to diagnose and to manage someone with a pulmonary embolism. So we'll do it with a case study because I find that often helps. One slide. So we have EF, who's a 48-year-old lady. She was brought in by ambulance with shortness of breath. You are the junior doctor on call for medicine. What will you do next? Some ideas, please, from the audience.
A to E assessment.
Sure.
Yeah,
But like in terms of the history, what critical things do you want to know as well? Assuming she's talking in full sentences and she is cognizant, so
Travel history.
that's yes, one of the things that you would ask. Anything else? That's one part, but history obviously.
Any cough, any pleuritic chest pain, like sharp pain in the chest, any recent travel history, like air travel, and if she is bringing up any phlegm, if it is frothy or if she has any hemoptysis. So we are going to ask all these questions.
Okay, so that's a good quick whisk through of what we would ask. So
I think that in the history, I would try to differentiate the shortness of breath, whether it's lung related or the heart related.
Sure, and how would you do that?
See if what is the background of the patient, if the patient had history of ACS or MI and risk factors, and also if the patient has asthma, COPD, smoker, etc. And if there's not much background, in terms of presenting history, what is the time frame of the onset, and when is the shortness of breath triggered, and is there any osopnea? And is there a trigger of a chest infection or symptoms of heart failure, for example?
Okay. Thank you. Anyone else has any other questions for the patient?
Any use of
contraceptives? Cancer, history of cancer.
Sure. Yeah. Thank you. Those were all very, very good suggestions. So I'm going to give you a brief summary of the history because we really need to focus on talking about PE itself. But let's say this patient is 48-year-old female, had a recent fall with an ankle fracture. She was on some painkillers, but otherwise nothing else. She has no known drug allergies. As someone asked about onset, so the shortness of breath came over the last 2 days. She is coughing up, so she is having hemoptysis, so she's got some blood speckled sputum. She's got some left-sided, someone mentioned pleuritic chest pain, and it is quite sharp, and it does come with inspiration. In terms of family history, I'm not sure anyone asked it family history. A lot of you said travel history and all that, but of note, family history. Her mother had a PE while she was pregnant. Okay, so this is the history. What would you do next? I think someone mentioned A to E examination as well. So I don't know if someone would like to elaborate what are the things that you would be looking out for if you suspected someone had a PE.
Like in examination, in A to E assessment, we'll assess the heart rate of the patient. We'll see, and usually we do well scoring for these patients, like for PE and DVT, if we are suspecting that. So on the basis of a well score, we will go for further investigations, like if we are going to do a D-dimer just to check whether it's high or not, or we will directly do a imaging CT scan, pulmonary angiogram.
Sure. And to go back to that's very good and all, but to go back to the basics. So in your is there anything else you would do besides you mentioned A to E and everyone said A to E, which is great. But what investigations would you do as you go along the way? If someone presented this shortness of breath over the last 2 days, etc., what investigations and
ABG.
What would you be looking? You mentioned cardiac, so let's see. We go back to B maybe. Let's see what will we be examining for?
Oximetry.
Yes.
Pulse oximetry and test the D-dimer.
D-dimer, that
ABG or ABG.
ABG, yes, very good. You might want to do an ABG. Any other investigations you would do in a breathless patient? For
Check
B.
the pulse,
Pulse
ECG,
oximeter.
Yes, you mentioned pulse oximetry. Someone mentioned that as well.
chest
A chest
X-ray,
X-ray.
pulse rate,
To go back to B, so not quite pulse rate.
Chest X-ray.
chest
Yeah.
X-ray.
Something very, very basic. Is important in PE. So everyone's very excited about the CTPA, but basic things like chest X-ray should also be done initially if appropriate. Sorry, and then you went on to C. So you mentioned pulse, like checking the pulse. What other investigations would you do in C? And what else would you be looking for, not just the pulse?
ECG.
ECG.
ECG is very good. Any other parameters you'd be looking at besides the pulse?
Blood pressure.
Blood
Blood
pressure.
pressure.
Blood pressure is very important. Very good. And then I guess those are the core things. And then D, anyone who's breathless, I guess you would, I mean, D, E, F, anything in particular you want to look out for?
Look at the legs swelling, differential leg swelling, pain, pitting, edema.
Sure, very good. Anything else?
Have swelling, any DVTs.
Yeah, that's good. Just as well, like in your ATE assessment, you always do a sugar as well. Anyone with hypoglycemia or hypoglycemia can present with shortness of breath as well. So I think that covers most of the things. And let me just move on to the next slide. So there you go. So just to give you a rough overview. So A, patient is talking in full sentences. In this situation, respiratory was 25, SATs were 90% of room air. Vesicular breath sounds of good air entry bilaterally, and there was no tenderness. I don't know if anyone mentioned, if sometimes you get pruritic because, muscular things, but in this case, there was no musculoskeletal tenderness. Heart rate, 110. It was sinus rhythm on the cardiac monitor. There was no confusion. Patient was not confused. No focal neurological signs. Blood sugar is as seen. Temperature was 37.2. There was no abdominal tenderness. No rash. The left leg was in a cast, and you noted that the left leg was quite swollen. I've just put in the boxes on the right your what investigations. You've already mentioned your ABG chest X-ray, but also you would do ECG and bloods. You wouldn't just do a D-dimer. I know everyone's very excited about D-dimer, but do make sure you do other bloods, because that will be important in terms of your future management. So how will you manage PE? You might need to give medication. And to do that, you will need to know other things like, what the full blood count is, what the clotting is, etc. So don't forget those as well. Okay, so let's move on to the next. This is the blood gas, just for your viewing pleasure. So the pH here is 7.48, PCO2 3.4, PO2 is 7, bicarb is 22, and base excess is 2. Any comments on the blood gas? We'll go through blood gases later in the COPD asthma one, but does anyone have any comments on the blood gas now?
Respiratory alkalosis. Respiratory alkalosis.
Sure.
Hyperventilation.
That's one aspect, yes. And what does everyone think?
Oxygen is less.
So patients also hypoxic in type 1 respiratory failure.
Yeah.
Type 1 respiratory failure.
Thank you. We'll go through ABGs later on, so I won't focus on this now. We'll just move on to the next slide. So this is the patient's chest X-ray. Any comments on this, or what we should be looking for in a patient with PE in particular?
Prominent
Okay.
vascular markings.
Sorry, I'm hearing a lot of things. Just sorry.
Prominent vascular markings.
Okay. Yes, you could have prominent vascular markings. Anything else that you'll be looking out for?
Wedge-shaped lesions or something?
Yeah. So you could have peripheral wedge-shaped pulmonary infarct. It's a possibility. Yes. And then anything else in terms of differentials, what would you be looking out for that good in terms of differentials?
PE,
Consolidation.
thorax. If
Yes.
there is a
Pneumothorax, correct. And I heard consolidation, someone I think mentioned. That's very important as well, because consolidation, so a pneumonia could also give you pruritic chest pain, potentially could give you hemoptysis as well. So it is important to look for
edema if you...
Pardon?
Pulmonary edema.
Oh yes, and pulmonary edema as well. So increased vascular markings, any signs of pulmonary edema, also very important to know. But yes, so those are the main things I think in a chest X-ray. Okay, and this is the ECG. I think everyone, a lot of this, I don't know if you've heard of the S1, Q3, T3. signs in an ECG in terms of PE. Now, this is the most common finding on ECG in PE is actually sinus tachycardia. Okay, you get S1, Q3, T3 if you have signs of right heart strain. All right, so S1 is the S wave, Q3 and T3. So you have a Q wave in lead 3 and T wave inversion in the same. Okay. And then you have a QR pattern in V1 and T-wave inversion in V1 to 4. Not all these signs will be present on every ECG. This is only if you have right heart strain. Like I said, the most common thing to find on ECGs is sinus tachycardia. So, I mean, the diagnosis is PE. This is a PE presentation, so I'll just move on. In terms of management, what would you do if you saw this patient and those were your examination findings, that's your X-ray, and your ECG showed S1, Q3, T3, and you suspect a PE. So what would you do next? I think someone mentioned wait for the D-dimer or CTPA. Is there anything else anyone would do?
If the patient is hypoxic and oxygen saturations are low, we will start on oxygen.
Very good. Yeah.
Yeah.
And what will your target stats be for this patient?
If there is no, it would be
94.
above 94%. Yeah.
94 to 98%. Very good. Good. And then you mentioned obviously doing the scan, etc.
When some CO2 retainers, should we then also maintain the saturation more than 94?
Sorry, I missed that. I'm saturations of 94 to 98. I got that, and then I totally missed what you were saying earlier.
Sorry. If the ABG is showing this patient is a retainer, then what would be the target stats then?
If they were known COPD, for instance, and they were known to be retainers, then you aim for 88 to 92. I'll go through that in my COPD asthma presentation later on.
If we are considering there is any embolism, we will consider like a blood thinning injections like anticoagulation heparin low molecular weight heparin or.
And what would you need to know to prescribe that drug?
INR.
Well score. No?
Creatinine clearance and renal function.
Yeah, indeed. So a lot of places now have point of care creatinines, which is helpful if you're waiting for the bloods and you think the patient needs urgent anticoagulation. So just make sure there are no risk factors. You can usually get a point of care creatinine and obviously their weight as well.
Yeah.
If they know their weight, great, but a lot of patients don't. So a lot of you mentioned in the history taking section, you mentioned a few things like travel history, etc. So I thought we could go through some predisposing factors for VTE. So strong risk factors, which means there's an odds ratio of greater than 10, you are 10 times more likely to get a thrombus. Are conditions like fracture of lower limb, which this patient had, previous thrombus, spinal cord injury, and actually hospitalization for heart failure or AF flutter within the previous few months, which is actually, it can be quite common in elderly patients. Maybe not this patient, but don't forget to think about PE in patients who have recently been hospitalized for these conditions. I think the more obvious things like, hip or knee replacement, major trauma, these things are more well known, but what's less known about is the fact that hospitalization also confers a risk of PE as well. Okay. And then on my next slide, I've got moderate risk factors, so odds ratio of 2 to 9. There are some things here that means you're at moderate risk of any VTE, so things like knee surgery, autoimmune disease, previous blood transfusion or recent blood transfusion, central venous lines, intravenous catheters, recent chemotherapy, congestive cardiac failure, hormone therapy, etc. So these are all moderate risk factors. Okay, IVF, someone mentioned contraception earlier, so that's important. Being in the postpartum period, particularly the first 6 weeks after giving birth. Infection, history of inflammatory bowel disease, cancer, obviously a well-known risk factor, but actually moderate risk factor, stroke, and thrombophilia. So things like that. Okay. Weak risk factors. So someone mentioned, I don't know if anyone mentioned sort of the, long travel or bed rest and things, immobility due to sitting. That's actually it is important to ask travel history, don't get me wrong, but actually it's actually a weak risk factors, ironically, not as everyone will jump straight on the travel and all, but actually stronger risk factors in that. So I just wanted to bring that to your attention. But things like bed rest, greater than 3 days, history of diabetes, hypertension, immobility, increasing age, laparoscopic surgery, obesity, pregnancy versus postpartum. So postpartum is a moderate risk factor. Pregnancy itself is actually a weak risk factor. And varicose veins, these are all weak risk factors. Okay, so you suspect that patient has a PE. In this situation, I mentioned the patient's blood pressure was fine. So this patient does not have hemodynamic instability. And the next thing you then need to assess is the clinical probability of PE. Everyone straight away jumps to D-dimer. And I know, and Wells scoring, I think someone mentioned as well. Now, when you assess the clinical probability of PE, you do use the Wells score or whatever scoring system your hospital uses to assess the clinical probability of someone having a PE, okay? So let's move on to, if they're low probability, then you would do a D-dimer. If they're high probability, then you would go straight to CTPA, okay? Now, someone mentioned the Wells score earlier, and here it is. In this patient's situation, I've boxed out in red what is relevant to this patient. However, most hospitals will have a printout of the Wells score in their intranet or whatever. So you can use that to assess, to give them a score, and that will give you the clinical probability of the patient having a PE. Okay, so there's the original version and the simplified version. That will tell you if a PE is likely or unlikely. So remembering the chart that we had here. So if a patient, based on the Wells score, is low probability or low intermediate or PE unlikely, then you would do a D-dimer test. And if it's positive, you would then do a CTPA. However, if the patient is high clinical probability, so based on the Wells score, high clinical probability or PE likely, then you would go straight for a CTPA. You do not need to do a D-dimer. Okay, so everyone correctly mentioned initiation of anticoagulation, especially if it's high or intermediate clinical probability. So what we're saying is if you suspect a PE and provided the no contraindications, you should start low molecular weight heparin rather than just waiting for the CTPA, okay? Each hospital, each trust will have their preferred low molecular weight heparin of choice. So you just have to ask for the guidelines for your local hospital and prescribe the right low molecular weight heparin. But this is the ones that are most commonly used. Okay, so PE has been confirmed. Okay, so you've done your clinical probability, you actually did CTPA, and the PE has been confirmed. So what's next? So you have a PE. What you then need to determine is how likely how likely is it that the patient will come to great harm, so have the early mortality risk of a PE, okay? And how we do that, we look at 4 indicators of risk, which is the top row that you see there. Hemodynamic instability, the PESI score, whether they have right ventricular dysfunction on an echo or signs on CTPA, and there's elevated troponin levels. So the first, hemodynamic instability. Let's talk about the definition of that. So there are three things that could form the definition of hemodynamic instability. If they have a cardiac arrest, obviously hemodynamic instability, that's the most obvious. But they could also present with obstructive shock, which is where you get where the systolic blood pressure is less than 90, or you need vasopressors to achieve a blood pressure of greater than 90 despite adequate filling status. That is important. So you need to fluid resuscitate the patient if necessary. And then if it's still, blood pressure is still rubbish, and you need pressors, that's one sign. But this must be accompanied with signs of end organ perfusion. So altered mental status, clammy skin, oligonuria, and another reason to do an ABG was to look at the lactate as well. And then the third thing that someone may present with in terms of hemodynamic instability is persistent hypotension. So once again, low blood pressure, systolic blood pressure of less than 90, or a systolic blood pressure drop of greater than 40, either lasting longer than 15 minutes and not caused by new onset arrhythmia, hypovolemia, or sepsis. That's important as well. Okay. So we've looked at indicator 1, which is hemodynamic instability. And if you have that, then you're automatically high risk, okay? So the second thing we're going to look at then is the PESI score, okay? And that's the pulmonary embolism severity index. Now, your hospital may use the original or the simplified PESI. I suspect simplified because it makes our life a lot easier. I do not have time to go through every single risk factor, but you can find the PESI score and have a look, and so that you know what to look out for when you're taking a history from patients. But essentially, we look at the PESI score looks at a number of factors, and that would including anything from both signs and symptoms and history, and that would give you a score. Okay, now basically most places will use the simplified PESI score because essentially if you get 0 points, then your 30-day mortality risk is 1%. If it's greater than 1 point, then your mortality risk jumps up to 10%. So anyone that's a simplified PESI of 1 and above would be considered intermediate high risk. Well, intermediate risk anyway. Okay, so what happens if you suspect, so we talked earlier, so the previous slide, we did talk about suspected PE in a patient without hemodynamic instability, okay? So what if a patient comes in and their blood pressure is very low, and you're very concerned that this has been caused by a PE?